Good afternoon. This is Trish Riley with the National Academy for State Health Policy. Welcome to our webinar, States and the Rising Cost of Pharmaceuticals, a Call to Action. This webinar, we're delighted with a great panel I'll introduce in a second. We'll report on a policy deliberation by a working group. We've identified 11 policy options states can consider, and we'll be exploring those today in hopes of beginning a conversation with many of you about next steps to make these ideas into reality in the states. We want to thank the Laura and John Arnold Foundation and Kaiser Permanente for their support of this work. Before we get started, just a couple of housekeeping details. You should be able to listen to this webinar through your computers. Phone lines are also available, and the 800 number is listed on the slide. At any point, you can ask a question. Please just post it in the chat box, and we will get to it at the end of the presentations during our Q&A period. Slides and recordings for this webinar will be posted on the NASHB website in the next few days. Let me, in the interest of time, quickly introduce our speakers in the order in which they'll speak, and recognize that we're just giving the tops of their titles because they're all very distinguished in their careers. Jane Beyer is the Program Officer for the Milbank Memorial Fund, and she is the Oregon Health Sciences University Center for Evidence-Based Policy. She will be followed by Nathan Johnson, who's the Chief Policy Officer and Head of the Division of Policy Planning and Performance at the Washington State Healthcare Authority. The authority is responsible for both the State Employees Health Plan and Medicaid. Representative Norman Thurston from Utah will join next. He's previously served as the state's Health Reform Coordinator and currently is also the Director of Utah's Office of Health Statistics. Finally, Dr. Amit Sapatore, who is a NASHB consultant, an instructor in medicine at Harvard's Medical School. He is an assistant epidemiologist at Brigham and Women's Hospital and the assistant director of the Program on Regulation, Therapeutics, and Law. With that, let me just begin with a few overview slides to put in context our deliberations. So we can go to the next slide. We want to focus on states because clearly states are purchasers, regulators, and policymakers. They have many tools at their disposal, and our work looks beyond Medicaid and looks at states as purchasers and regulators broadly. Obviously, the issues that drive states to this deliberation are several. Launch prices for new drugs are unpredictable. They're increasing frequently. And as you all know, states with balanced budget requirements are really challenged with these unpredictable and high rising costs. And one need only look at what few statistics we have. Clearly we need better data, but we know that there's enormous spending on public employees, $31 billion in total, 19% of that is on pharmacy, a rapidly growing cost. In 2014, Medicaid programs spent $27 billion on outpatient drugs, and that's just outpatient drugs. And in 2011, before the Hep C crisis and the new drugs that were available for that disease, corrections programs were spending $8 billion, so that clearly underestimates what they're spending. On the next slide, just a reminder that frequently federal policy changes after states are laboratories of innovation and design. The State Children's Health Insurance Program was enacted only after 26 states had similar programs. The insurance reforms under HIPAA and, of course, the ACA itself were all led by states first. So we think there's great opportunity and we'll go to the next slide, great opportunity for states to really, again, show the way, particularly as the federal government changes administrations and there are questions about what the federal government should and can do for drug policy. We think states can be great leaders. This is just a listing of our great work group. It's cross-agency. It crosses executive and legislative branches in order to get the full view of state government to the issues before us of how to bring down the trajectory of high drug prices. Our organizing principles on the next slide were fairly high level. We believed that the old approaches are no longer sufficient, that states have been extraordinarily active in a variety of areas listed here on this slide to try to rein in costs. Some have been more successful than others, but our thinking was that there's a great deal more that needs to be done and that we need to think differently about the industry and perhaps think both about the carrots and sticks available to state governments as we think through the alternatives that might help us lower drug prices. And on the next slide, we spell that out briefly. clearly we have to recognize the value of the industry. It's easy to point fingers. It's easy to talk about the high costs. The reality is that obviously the pharmaceutical industry is providing drugs that have extraordinary impact on the quality and quantity of life. They are innovators. It's terribly important. Every state knows where there's a pharmaceutical industry placed in that state. They're job creators. They have significant impact on the economy. They ameliorate disease and disability. And for them, the world is changing as well, as listed here on the slide. So it's an appropriate time for us to think about a changing environment for both the states and the industry. This next easy-to-understand slide shows you one state's attempt to unbundle the black box of pharmacy pricing. And we're not going to spend any time at all on it because it's just so completely complicated. And as one of our panelists notes, there's still plenty of black boxes. This is an extraordinarily complicated field and one that we think our 11 policy options begin to address in bite-sized pieces that can move the ball. Let me now turn to Jane to talk about a project independent of our work group, but with whom we're collaborating closely, the Smart D project, which is focused on Medicaid. Jane?
Good afternoon. Thank you, Trish. Can we go to the next slide? So the Smart D project is essentially a 3-year, 3-phase pilot program and also supported by the Laura and John Arnold Foundation that is being carried out through the Center for Evidence-Based Policy at Oregon Health and Science University. Essentially, we have 3 goals: to give states the support that they need to be able to develop alternative payment methodologies for Medicaid prescription drugs, and then to provide those Medicaid programs with the opportunities to shape the conversation around prescription drugs. We've completed phase 1 of the project, in which we did a lot of baseline research, and you'll see from when I get to it, the next slide, we've put that all on the web, so it's publicly available. We're currently in phase 2 of the project. We are working with our first group of states to develop alternative payment method implementation plans and providing extensive technical assistance to those states. And this would lead in mid-year of this year into working with those states and others with interest to actually implementing pilot projects. And when we refer to alternative payment methodologies, essentially we're referring to mechanisms that move out of the classic volume rebate kind of a system into linking prescription drug coverage to value-based purchasing and bringing it into the 21st century in that respect. Next slide. And here is a link to our website. It lists the reports and the research that we've already done. We have done extensive legal research on the current Medicaid drug rebate program and pathways that we think are available under that program for states to pursue APMs. We did an economic analysis of high-priced prescription drug spending. We have extensive research on the use of alternative payment methods for prescription drugs elsewhere in the United States and nationally, and then a report, as Trish referenced earlier, around how states are currently using what limited authority they have to manage prescription drug spending. I think we can say that the MDRP constrains state Medicaid programs' ability to control both utilization and spending for prescription drugs. Under that system, as many of you know, states essentially have 2 choices: opt not to cover prescription drugs at all, since this is quote-unquote an optional service under the federal Medicaid statute, or cover all drugs that are offered by manufacturers who have signed a rebate agreement with the federal government. Thanks, Trish.
Let's move to the policy options. I'll take the first 2 quickies so that we can get into the more detailed ones. The first is to ensure state participation in Medicare Part D as employer group waiver plans. States that provide pharmacy benefits to retirees can establish an employer group waiver plan. That plan, and many states do but all don't, so we encourage states to look at this, since the EGWP allows employers to access Medicare funding for retiree pharmacy benefits and thereby create savings within the retiree health plan, an important initiative for states to look at. Our second proposal is to look at pension funds and suggests that state pension funds can assume an active stakeholder role to influence pharmaceutical company actions. Public pensions hold $3.8 trillion in assets, most in securities. With mutual funds, they're the biggest investor in the stock market. Obviously, states struggle with unfunded liabilities for pensions, and they can sometimes find themselves pitted against the costs for rising pharmaceutical costs in state employee health plans and Medicaid. So the issues are common in a curious way among them. Importantly, these publicly traded companies must provide voting rights to shareholders to hold companies accountable. This proxy voting can deal with election of directors of companies, advise on executive pay, buyouts, and mergers. Shareholders, importantly, can submit resolutions to corporate boards. Not long ago, a activist shareholder group, As You Sow, compelled McDonald's to consider more environmentally friendly beverage containers. They did a proxy vote, they went to the board, they got 29% support, and the McDonald's Corporation did indeed change their beverage containers. CalPERS is also an active purchaser. We're identifying much public transparency in its investments. And it is an initiative where states can think about their clout, their tools as investors in pharmaceutical companies, because the reality is, as much as we are focused on the rising cost of pharmaceutical companies, the fact is in our state pension funds, the more profitable a pharmaceutical company is, the more benefit it brings to the pension fund. So why not trigger those two activities and become an active shareholder? With that, let me turn to Nathan to take us through two more policy options.
Thanks, Trish. The first one I want to address today is called out as Strategy 1 actually in the report, and it's around increasing drug price transparency. I take great interest in this issue and all of the issues raised in this paper. With Healthcare Authority, we are the largest healthcare purchaser in the state. We spend $10 billion for serving over 2.2 million people. Of that $10 billion we spend each year, over $1 billion is dedicated to prescription drug costs, net of rebates. And that, of course, is the fastest growing portion of our health spend in this state. Dealing with drug price transparency is a twofold proposition. First, dealing with unit price or actual drug costs, and the second, more speaking to the purchasing element of this, which is after everyone is paid, and many people need to get paid, as the earlier chart referenced by Trish was clear in showing, what is the actual net cost a state is paying for drugs. So our report addresses this and deals with four components of price transparency I'll briefly mention here. The first being drug development cost reporting, the second requiring justification of price increases, the third public disclosure of price discounts and rebates, and the fourth confidential disclosure of price discounts and rebates. And I'm going to spend just a few moments on the latter two, which are again of great interest to Washington State. We have experience with a pharmacy benefit manager on our public employee healthcare side where the PBM arrangement and the drug costs are transparent, and it's a contractual requirement. Again, referencing the chart earlier showed by Trish, that does not exist on the Medicaid side, and it's very, very difficult for policymakers, for budget writers, and for the state to have an understanding at any given point in time what the true cost of a drug, a particular drug or class of drugs is, and its impact on the state budget. So when we deal with the specific issue of price discounts and rebates, understand that the Section 1927 of the Social Security Act prohibits disclosure of this unit price information to any external party. So but for a few staff in our agency, no one understands the actual drug cost at a unit price level, and it makes policy discussions and budget discussions that more difficult. So we conceive of in the paper a variety of policy approaches, but much of which would need to be dealt with at the federal level for getting to a greater level of transparency on drug costs at a unit price level and at an aggregate level going forward. The second policy option I want to briefly reference, which is related, is leveraging Medicaid flexibility to promote purchasing flexibility. We raised several policy options in the paper I'll briefly highlight. The premise behind all of these options, I should suggest, is that the state could get a better deal through doing one or all of these elements. The first is using a waiver process to allow the state to opt out of the mandatory Medicaid drug rebate provisions of Section 1927 of the Social Security Act. This is a matter of federal policy, and it would require, from our perspective, a federal statute change, or at least that's what we think at this stage. But the notion here again would be free of the rebate provisions, the state would be able to negotiate a better deal. And just quickly, the second is to allow states to utilize the waiver process to opt out of Medicaid rebate provisions only for a limited number of drug classes, with the idea being that there are some high-cost, high-impact drug classes for Medicaid populations that might deserve a new and more concerted focus around service delivery options, new co-payment structures, etc. The third is to allow states to waive requirements of the rebate law while maintaining access to minimum and best price rebates, kind of the best of both worlds approach. And finally, we raised the idea of spreading out Medicaid rebate laws to cover other key state purchasing, whether for corrections, for labor and industry, or what have you, whatever the state environment would allow. So this is transparency and Medicaid flexibility in a nutshell, and Trish, I'll turn it back over to you.
Great, thank you, Nathan. And we would encourage people to add your questions into the chat box at any time, and again, the slides will be posted on our website in a few days following this webinar. Let me turn now to 4 different policy options and ask Norm Thurston to take it from here.
Great, thank you, Trish. I think some of the people on the line might be wondering how it is that a conservative Republican legislator from Utah might be involved in an enterprise like this, but I want to assure you that in the process of developing the recommendations, we wanted to be as broad as possible. We wanted to find options that would work for all the states, not just for a few. And so there are options here that I think are definitely interesting to me personally and to our state as well, and that are possibly things that we could actually implement. So one of the things I do want to talk about, there are 4 on here. I don't have time to talk about them all in detail. But let me just start with talking about this idea of the public health role of government. You know, one of the things that we do as a public health entity in the government is we try to do things in bulk purchase so that we can get the most bang for the buck on public health activities. And part of the problem is that some pharmaceuticals, the incentive for any given person to make the effort to go acquire them and pay the full cost is not fully reflected in the market price, because that person's saying, well, yeah, there's a benefit to me, but there's a larger public benefit for which they're not compensated. So in those cases of externalities, we think there's an underutilization of those pharmaceuticals, and that's distorting the cost-benefit decision-making. So one of the ideas that we have is to leverage the public health component of our government, and in some cases where expensive drugs actually have that public health response, to use that public health volume purchasing and mission of the government to negotiate a statewide version of purchasing them. And we're already doing this, for example, with vaccines, especially with the VFC program, Vaccines for Children program. We're already doing it there. And it might make sense to look at some of these other high-cost drugs that have a public health nexus to do that. The second thing here, and the slide says re-import drugs from Canada. I'm not sure why it's re-import, because sometimes those drugs are actually not ever in the U.S. We're actually just talking about importation from Canada on a state-by-state basis. The rules have been in place for a while, but as far as I know, no state has ever actually tried to do importation of drugs from another country. So I would be wholly in favor of some state giving this a try to see what they could figure out, how we can make it work, how we can streamline the application process. Does it actually end up saving money? And furthermore, if it were up to me, I wouldn't restrict this to just looking at Canada. I think there are plenty of other places that we might look to that have safe supplies of pharmaceuticals, but that's kind of how the rules are written right now, so we're restricted to looking just at Canada. Also, this idea of the state as a pharmacy benefits management company, and you just think about how much taxpayer money total is being spent on drugs. By the time you've got state employees, the higher ed system, the public ed system, corrections, Medicaid, and the list goes on, we have a lot of people out there that we're using taxpayer money to purchase their drugs. But we don't coordinate. We have no coordination across all of those different populations for things like preferred drug lists or formularies or bulk purchasing or any of that. So another idea that I think is fairly workable for a state like ours would be to combine all of those public responsible entities into a single entity, which would be much larger and be able to coordinate our own business as a state government for the people that we're going to be paying for it. If you look at what states actually do, there's no rhyme nor reason to what happens on the Medicaid benefit versus the state employees benefit versus what happens for people who are incarcerated or public school teachers for that matter. And so that's an area where I think we can make some real progress. And then finally, this is the greatest idea in the paper, but the one that's the most complicated to explain. I will never be able to do it on a webinar, but would encourage you to study the document and try to figure it out, and certainly ask questions if you have them. But the ROI pricing strategy puts the rhetoric to the test. For years we've been hearing from pharmaceutical companies that this drug should be expensive because it works so well, it will save you so much money from emergency rooms, from other hospitalizations, and so you should pay us a lot of money because we're going to save you a lot of money. So this pricing strategy actually puts that to the test and says, great, we will agree to value-based pricing. We will pay you more for drugs that do a better job, but we want to use forward funding to finance this so that the money goes out only after we see that the promised results actually materialize. We're not just paying you all of this money on your say-so. We actually will engage in programs where we track individual patients over time and see how much savings the drugs actually generate and use that as a vehicle for doing that. And there's a lot more to it than that, but at least that gives you some idea of kind of the general flavor of where that's headed. So there are some ideas here that red states could apply for, or that could apply for red states. And I'm fairly excited about maybe giving a few of these a run here in our state in the next year or two. Thanks, Tris. I'm going to turn it back over to you.
Great, Norm. These are hard concepts to do in 5 minutes, so we do encourage you to add your questions to the chat box, and we'll be able to explore them further in Q&A. Let me now turn to Amit and ask him to walk us through the last 3 policy options.
Hi. Thanks, Trish. And so we've heard a little bit on market-friendly mechanisms to facilitate state efforts to control drug costs. I'll be talking a little bit more in my first one on the public utility model, which would be a regulatory-heavy way to approach the situation. And here, what we're really saying is drugs, in some respect, are no different than water, electricity, and gas. They're critical goods. And in that respect, the state should have the right to regulate them as they would other public utilities. And what that would entail was having a drug price review board that would consider drugs with very high launch prices or price increases and have the power to conduct open hearings, to collect data from manufacturers, to commission studies, to approve, reject, or even tax or price set in those instances. And this could be a standing committee with fixed terms from diverse representation. In this particular situation, the state does have a considerable amount of power to act on behalf of its citizens, but there are legal challenges. One would be, as in terms of regulating a public utility, the state has an obligation to provide a reasonable rate of return. So it needs to determine what a reasonable rate of return is, but has considerable discretion in that decision-making process. The second, more considerable challenge is this issue of whether or not preemption would apply. And what I mean here is whether or not federal law would in any way prevent states from taking this action. And this is an open question. In 2007, the Federal Circuit, a federal appeals court, decided a case called Bio versus the District of Columbia, in which it said that a Columbia statute, a D.C. statute that went after specifically patented products, contravened sort of federal patent law. And what we don't know here is this is sort of an arrangement where the federal government says, look, we're going to provide this scope, an incentive for you to produce drugs, and in exchange, we will allow you some discretion to charge a price premium. And the question here is whether or not companies that engage in extreme pricing violate that compact, and whether or not states have the right to step in that instance. That's something that states will have to navigate. The consequences of this also need to be considered. You will hear pharmaceutical companies say that innovation will suffer, but there's no empirical data to that. Right now, when we consider pharmaceutical companies, there's a 24% profit margin forecast for 2016, among one of the highest. And in addition, high drug prices can be justified under a public utility model if it provides value. Finally, there's the issue of political feasibility. The American public, a vast majority, 78%, favor some sort of drug price capping. And so if there is a time to act, now would possibly be it. The second approach I'd like to discuss is consumer protection, and this really has two prongs. The first would be unfair trade practices, and this is a sort of nebulous definition, and it means immoral, unfair, or causing substantial harm. And in the pharmaceutical context, it might mean predatory pricing that distorts consumer behavior to their detriment. And here there's not a lot of good law out there as for whether or not how much discretion a state attorney general might have in terms of pursuing predatory pricing. But there is a Massachusetts case study with regards to hepatitis C that came out recently. And here, hepatitis C is a serious and life-threatening disease and in terms of who has it. Generally, it's higher in prevalence among vulnerable populations. And there is a Massachusetts law that allows the Attorney General to make rules and regulations interpreting provisions of going after unfair methods of competition. And here, the Massachusetts Attorney General did so and threatened Gilead, the company making Sovaldi, saying specifically that the prices were too high, and as a result, patients were not getting access to their medications and suffering adverse health outcomes. Experts were very skeptical of the possibility of her prevailing in this case. One quote was, "I think she loses in Massachusetts and any other court in the country." And yet, spotlighting this issue created an unfavorable environment for the company, and they were willing to negotiate and provided a supplemental discount to Massachusetts Health. A second aspect of consumer protection is to have state involvement, greater state involvement in pursuing antitrust laws. So one proven method to reduce drug costs is early access to generic drugs. But what we've seen in terms of the dynamic of the marketplace is oftentimes pay-for-delay tactics, in which generic manufacturers agree to refrain from entering the market in return for something of value, cash, or something like a licensing agreement. And in 2010, there was a Supreme Court case in which the Supreme Court said that such agreements could violate antitrust law. And since then, you've seen a rapid fall off in terms of actual cash transfer pay-for-delay cases. But you still see these non-cash transfer pay-for-delay cases, situations in which what a company is offering, what a brand name company is offering a generic company, not necessarily money, but something else of value, such as an agreement not to market a authorized generic during the first generic's exclusivity period. And here you could have an attorney general coordinate action. You could have a group like the National Association of Attorneys General take targeted action to bring suit against such agreements under state antitrust law. Finally, I'll discuss misleading marketing, and here that's the concept with relationship specifically to drug coupons. Now, drug coupons generally reduce out-of-pocket costs, but not third-party costs. So the patient pays less, but the insurer and the system ends up paying a lot. And these programs have been increasing in number. In mid-2009, there were 86 programs. At the end of 2012, there were 525 programs, a 612% rise. The limitations of these programs are that they're time limited often and of restricted eligibility. The indicated population may not necessarily be the population for who can actually access the coupon. And so there's also the problem that they distort the payer mechanisms to patients in terms of steering patients towards rational drug choices. A recent study found that drug coupons increased total spending $700 million for branded drugs first facing generic entry between 2007 and 2010. And this savings that was foregone was resulted from a lack of pursuing bioequivalent generics. So that means that consumers were not taking the same cheaper alternative, the exact same, and as a result spending more. And so this labeled the study author to call drug coupons a wolf in sheep's clothing. Now, these coupons aren't allowed for federal programs because they're considered a violation of anti-kickback statute, but they are allowed and oftentimes permitted in private health insurance. And so if a state is acting not necessarily here as a payer, but or as a payer not in federal programs, so as a state employee, on behalf of state employees, you could consider a state taking action against drug coupons to make sure that at least they are marketed properly. So to make sure that the disclosures as for the duration of these coupons and the eligibility requirements for these coupons are clearly specified, or that the state imposes minimum eligibility or duration standards. And finally, the state could consider banning the use of coupons when bioequivalent generics for that particular product are available. So these are three policy options that are among the overall toolkit of policy options that state could consider. So I'll hand it back to you, Trish.
Oh, sorry, I was on mute. There you are. How impressive. Thanks, Amit. Can you follow up on the public utility model just a little bit? There's been a question, obviously not a surprising one, about the Interstate Commerce Clause. And wouldn't there be implications in a PUC model of conflict with the Commerce Clause?
Hi. Yeah, I personally don't think the issue is so much the Commerce Clause, because I think that the state could consider, as long as the state is, there's not going to be a dormant Commerce Clause issue in terms of what the market is. We're not charging differential prices for products that are produced elsewhere versus those that are produced in the state. I think the issue is really one of federal preemption, whether or not the granting of a patent is in some way the federal government occupying the space, so to speak, and saying that states don't have the ability to interfere with pricing of those products that have market exclusivity. And that's the issue that I think is an open question.
Okay, thank you. And I'd also want to go back quickly to on the reimportation or importation from Canada. We think there may be opportunities for states here. Again, it would put the state in a pharmacy benefit role or contracting with one, but to purchase drugs from Canada. But not only does the Secretary of HHS have the authority to grant such an approval, but there's now a Drug Quality and Security Act of 2013 that addresses one of the key provisions that kept reimportation from becoming a reality, and that was concerns about the quality. So we think there are now some quality protections that didn't exist before. I wonder if I could ask the panel to talk a little bit more, all of you, about transparency. Transparency seems to be a baseline. We need transparency to do utility regulation and to do a number of these other activities. It's also oftentimes not enough. We can't satisfy ourselves that transparency would be adequate. I wonder if we could explore a little bit more, and maybe Amit, you want to start, and Nathan jump in, about when we say transparency, what do we mean?
Sure. So I think it's important to first recognize what's been done with regard to transparency. And a lot of the efforts in terms of state bills have focused on considering the development costs of drugs. So in the case of high-priced drugs, let's have manufacturers tell us how much did it cost to make this drug, and to see if there's a really big disconnect between the price charged and the price of production, or the cost of production. And there the question I think one needs to ask oneself is, does it really matter? In the same way I pay for an iPhone not based on what I think was gone into the production cost of the iPhone, I pay for it on the basis of value. So that sort of information may help in the cases of extreme price gouging in terms of possibly providing some leverage, but on the whole, it shifts us away from more considering the value that drugs offer. I think there is scope for transparency being quite beneficial, though, for states, and I think Nathan brought up a good point that at least in the Medicaid context, there's some limitation as for what states can do. But remember, states aren't just acting in the Medicaid context; they are also acting on behalf of their constituents. They're also acting as employers, and so as an employer. And in that instance, I think it's helpful for states to know there's a lot of finger pointing going on between pharmacy benefits managers and drug companies as for why drug prices are increasing and who is actually securing that profit from that price increase. And it's a convenient sort of tactic. You can continue pointing fingers at one at the other. And the thing that the state doesn't know is really where is profit being extracted along this chain, and thus where should action on the state basis be directed. So I sort of view transparency, and the same thing can be said about so-called 340B programs in terms of programs that offer money, that offer discounted products to hospitals and other groups that are providing drugs to underinsured people. And in that sense, having this information, again, it's not a panacea, but it's a first step in better decision making. And in that sense, using capital to secure that information might be worthwhile. But again, I'd put the promise of transparency isn't always what it's sort of hyped to be.
Yeah, thank you. And I think that's important that when we talk about transparency, we talk about pharmaceutical manufacturers, about PBMs and 340B, so comprehensive transparency. Let me turn to Nathan. We've had a new question, Nathan. You can certainly join the add to transparency, but one we've heard before, which is what makes the state think it could do better than the rebates? Obviously, states get great windfalls from the rebates. What makes a state think that they can do better outside of that framework?
Oh, that's a great question.
Jane might want to join too.
Yeah, well, we don't know because it's not legally permissible at this stage. So we are raising the question in the report for a reason, largely because the precedent has been set with the rebate law on what a fair discount for purposes of serving the Medicaid population is. And there is some that would believe that a state using that precedent could negotiate more effective, more targeted deals and not be bound by the more negative provisions of the drug rebate laws, at least in terms of flexibility for program administration. So it is an open question. I guess what makes us think it is there is precedent established on what should be paid for a Medicaid drug, and there may be willingness from certain manufacturers to work on alternative arrangements outside of the strict requirements of the drug rebate law. So it could work favorably both directions, actually, in that regard. The other thing I do want to mention while we're on that subject is maybe to correct an earlier misstatement regarding 1927 and applying for a waiver that would allow some of this flexibility. I think there is more of an open question, and states, there may be some states already exploring it with CMS as to whether certain provisions of 1927 could be waived. I think earlier I suggested it would need a statutory change. I'm not so certain that's the case. But I would also, on the transparency question, just going back there briefly, Tricia, agree with the earlier comments and also add that there is some really great precedent that's been established in some state programs around public employees with really transparent pharmacy benefit manager arrangements where all of the costs are well known to the purchaser, all of the discounts are passed back to the purchaser, and I think that's an interesting model to explore across state purchasing, but also to ask questions about in the context of Medicaid as to whether we could get to something resembling that level of transparency.
Thanks, Nathan. Jane, anybody want to add on the rebate issue?
Yeah, so several thoughts. First, when there is no question that when we were putting together the legal pathways and thinking about for the alternative payment methods and how states might think about using them, that we were very sensitive to the fact that states are heavily dependent financially upon both the statutory rebate that they get under the federal statute and supplemental rebates that they negotiate. With that said, Some of the pathways we would argue that we identified in our research can take a state outside of the MDRP. Admittedly, the risk of that is losing the insured rebate. The opportunity of that is the opportunity to not have to pay or cover all of the drugs in a class. So in a drug class where you've got competition, it's an opportunity to have greater competition if you're essentially able to establish a formulary. The other thing to think about that we've been talking to some of our participating states about is using rebates differently, so that rather than just having a negotiation around a supplemental rebate that says, if I put you on the preferred drug list, I'm going to get you X% more in terms of a rebate, is using those rebates differently to think about things like use of drugs based upon indication, where the rebate might vary based upon what the indication is. And lastly, when states are thinking about which drugs and whether to give up that opportunity for the statutory rebate, remember that depending upon the kinds of price increases a drug has experienced, how new it is to the market, how old it is to the market, whether there are generic versions, there's a pretty significant degree in variability of even what the statutory rebate is under federal law. So all of those things would be taken into consideration by a state.
Great, thank you, Jane. Let me turn to another question. In our first paper, I would refer you to a paper we wrote early on in the work group's deliberation, States and Prescription Drugs, an Overview of State Programs to Rein in Costs, where we went through the historic activities states had engaged in. One of those was multi-state purchasing collaboratives. And we have a question about whether those multi-state purchasing collaboratives can be more effectively used for Medicaid, state employees, teachers, and others. Nathan, I know you have a lot of experience. Can you speak to that?
Yeah, we have had a lot of success. We work very closely with Oregon on our purchasing drug consortium, and it provides a lot of value from pooled purchasing. Some of its limitations are it does not operate around a single formulary, so each state is still left to devise its own formulary approach. And one of the other limitations we, of course, run into is its application to Medicaid. These drug consortiums, at least our experience with them here, have been most applicable and most helpful with our public employee healthcare business, and we have not yet devised a strategy for applying them to Medicaid, largely for the prohibitions and limitations of the drug rebate statute. But that said, pooled purchasing across states brings an economy of scale, brings leverage in negotiating that doesn't exist otherwise, and also allows states to share in tactics. Even when the formularies are different, some of the purchasing tactics can be better aligned to achieve those state objectives that exist. So far we've had a great experience. We also extend our consortium, and have for many years, even prior to the ACA, to individuals who may not have great prescription drug coverage. They're able to access our discount that's negotiated through a discount program that the state administers, which has also been very successful over the years.
Great. Anybody else want to speak to that question of the multi-state consortium? We did have a question noting that if states were active use their pensions as active shareholders, that they could shoot themselves in the foot effectively, bring down the price of the profitability of pharmaceutical manufacturers, and you hurt your pension plan. And I think that's absolutely possible. But you can also use that strategy to encourage pharmaceutical companies to become more transparent and to meet other policy goals that are outlined here in this paper. And I don't know, here's a stump the star question. Amit, do you happen to know the citations for Bio v. District of Columbia?
Oh, I don't have it off the top of my head, but can we provide a way to put it online? Yeah, I just don't have it with me.
We will definitely, that was almost cruel, but I thought, you know so many things, I thought it was worth a try. We will definitely post it when we post the slides.
And to whoever asked that, my apologies. I'm sorry.
Any other questions or any other comments from our speakers? We have a little bit of time. Norm, we gave you short shrift. If there's anything more you want to add, come at it.
No, I'm good, but thank you very much.
Okay. Let me just see if are there any states that are currently, operating a state pharmacy benefit manager model? And I don't believe there are. I think we're looking for somebody to work with us to create one. But does anybody know of somebody who has a state PBM? Yeah, I don't think.
Yeah, Trish, just one thought on that. I mean, when you think about a state like, for example, Connecticut, which opted out of the traditional managed care approach, has an ACO. So for their Medicaid program, they have a single pharmacy benefit manager in essence. The question, and I think, or the issue, and Nathan actually referenced this earlier, is for any state that's thinking about a multi-payer approach that includes a Medicaid program, the provision in the MDRP that essentially says that a pharma company needs to give its best price to any Medicaid program can create a barrier, because if you've got a Medicaid program, a state employee program, and your corrections agency all wanting to contract with a single PBM, that PBM negotiates a quote-unquote a really good deal. The deal that manufacturer of that drug gave that PBM needs to be offered to all of the other Medicaid programs because of that best price provision.
Right. Good point.
So unless something like that can be done alongside like an 1115 waiver, where there's some sort of a mechanism to try to provide a safe harbor or something around that best price provision, that's the challenge with a single PBM that's purchasing for multiple state programs. And because, as Nathan indicated, I mean, Medicaid is the biggest purchaser in the state generally of prescription drugs.
Right.
So that's the challenge there.
Yep, that's a very important challenge, and the Medicaid implications are real. As is, even if a state created this magical PBM, the issues of transparency are really important to know what exactly those discounts are, because to the earlier question, unless and until we know what's inside the black box, it's very difficult to make some of these policy decisions. We have an answer. Bio v. District of Columbia, number 06-1593, Federal Circuit, August 1st, 2007, and we will post that as well. Okay, with that, let me move to just some quick.
Oh, sorry.
Yep.
I was just thinking it might be helpful for you to just give a little overview of what NASHP is doing in terms of pursuing this value-based payment movement.
What a segue. Let's move to next steps. That's great. We are particularly interested in this notion of changing the relationship between purchasers, state purchasers, and the industry. Recognizing the industry tells us, and they correctly tell us, that these drugs have long-term implications on improving health and saving money. A drug that could address ADHD has extraordinary potential to reduce education costs. Drugs can reduce emergency department use, can reduce nursing home use over the long time. Getting the ROI on that right is pretty challenging. But for states, the flip side of the states is these extraordinarily high launch prices make it very, very difficult to just purchase the drug and open it up to everyone who needs it. We create all kinds of constraints to try to deal with the budget. The notion here is we agree with the industry that there's a return on investment for many of these drugs that is important and real. We are less inclined to want to be able to measure that purely. I think of Medicaid budget neutrality issues, but to use it as a negotiating tool to think about how we could think differently about negotiating a lower launch price and a more predictable price for a drug over time. Secondly, then, it would be, in our thinking, very intriguing to work with the industry on a return on investment pricing strategy, in which the industry provides drugs up front and the state is allowed to pay for them over time. and budget them in regular 2-year budgeting cycles, know what their obligations are, and be able to predict and budget in a more reasonable way. So it's a way to negotiate with the industry in ways that we have not done, that moves us in a different pathway, to contract with them on an annual basis and to renegotiate and revisit as we know pharma is a fast-moving field. It's an area where we, and again I've given much too short a shrift to it, but it's an area where we very much want a state partner or state partners to work with us. We know we've met with the pharmaceutical manufacturers, and we know that there's interest in companies working with us and with the state to think about a new way to take on one of these blockbuster drugs. The next one, you know, we all know the experience of Sovaldi and the Hep C drugs, what's coming down the pike. We will be watching more closely what's in the pipeline for new drugs, keeping states informed of that, identifying drugs that might be these kind of blockbuster drugs that have great potential for return on investment over time and savings to states broadly. And we want to be able to work with states, the industry, to be able to think through this forward financing and return on investment strategy. But what we need is a state partner or partners. So we very much want to hear from you about your interest in joining us. We'll have the capacity to provide support, consulting, the technical kind of expertise that's necessary to really dig into these issues. And that's true of all 11 of these proposals. We very much want to identify states who can join us and be partners with us in making these ideas real, and recognize that they're just ideas, many of them at this point, and very much need to be fleshed out and thought through. We will soon be releasing model legislation on transparency. We are hoping to be able to do model legislation on reimportation, and we are very much hoping to really dig into the very real issues of the economics and actuarial analysis of many of the issues, including the return on investment strategy. Our next steps are to find partners to work with, to flesh out these ideas, to get some models going in states that can be replicated in other states and can inform federal policymakers. And we will be meeting in the next month or two with the pharmacy benefit managers to talk about our proposals and their concerns about them. So we view this work and this working group as very much a work in progress. Our efforts together, and again, I think it's been really important to have at the table corrections, the attorneys general, comptrollers, Medicaid, state employee health plans, and many more, so that we can get ideas out there. But to make them real, we have to sort of work hand in glove both with the industry and with states. So with that, any of our panelists who'd like to add anything? We would encourage states to let us know if you want to join us. We very much want to begin a dialogue with states and move this beyond a set of policy options to actual policy. And we hope to encourage you to do that. We will be posting the information again in a couple of days that you heard here on the webinar. Please keep in touch with us. We will keep you informed as we move these deliberations in more detail with the work group. And with that, I want very much to thank Jane Beyer, Nathan Johnson, Amit Zapatori, and Norm Thurston for their great participation, and to thank all of you for participating. Thank you all.
Thank you, Trish.